Yes, we are. Thank you, Mr. Chair. Joining us today is Dr. Miller, who's already been here today, and Dr. Varghese. We have a series of I think it's about 11 or 12 slides to walk through. Ruben is going to give an update. There has been a lot going on in the area of vaccines, and thought it was appropriate to check in with the board and the community and give an update. So once Ruben gets settled in, and Kendra, I think you have the slides. Over to you, Ruben.
Thank you, Ms. Jacobs. And Dr. Varghese, when you're ready.
Good afternoon. Happy to be here, and at some point I'll turn it over to Dr. Miller so you can get a break from hearing from me a little uninterrupted. So I thought with the boosters from Moderna and J&J nearing approval from FDA and CDC, should be this week, we hope, and then the vaccines for 5 to 11-year-olds hopefully to be approved sometime in the next 2 weeks, and juxtaposing that with the death of Colin Powell from COVID-19, I thought I would use the time to review the pandemic in Arlington, which many of what lessons we've learned are going to be repeated in some ways because some of the basic underlying characteristics of both the disease and the people who are affected remain the same, although we are very glad that vaccines are present. So if we could go to the next slide. So I think this is a familiar pandemic curve since March 2020. We are in our third wave that we're experiencing in Arlington. And while the numbers are officially down, I do have 2 comments. We are still in the second highest category of community transmission, which the CDC refers to as substantial. We have been fluctuating between substantial and high, which is the highest category of community transmission by CDC's classification at this point, and that's not only true for us, but for the region. And my second comment, we know that this is an underrepresentation of the number of cases present. We know that people are either not getting tested because if they're symptomatic, they may just assume it's COVID and don't go for testing. Hopefully they're staying at home. And there are those taking at-home tests which are not necessarily reported to us. So if we're at substantial officially on the chart, I wouldn't be surprised that we're actually still in substantial community transmission. So I don't think it's any stretch of the imagination to say that there's still a pandemic right here in Arlington. And what is different is that we have vaccine and we have gotten better adjusted to the presence of COVID in our community. Next slide. So this is from the website. This is a snapshot of the summary of COVID data since March 2020. But I think just hearing the numbers, we have had 18,354 cases, which as I said is an undercount. We have had 918 people hospitalized and 269 people who have died. And on the latter, that is 269 preventable deaths too many. Next slide. This graphic is a reminder that while all parts of Arlington experience COVID, some of the people experience in these areas much more COVID than others. This is the distribution of COVID cases by zip code in Arlington. The areas in orange depict the zip codes with case rates above the Arlington average, which staff include, which is at 7,727 cases per 100,000. That's still a lot of cases. And those below that have less cases, but of course, obviously, it's still indicating we still have a lot of disease. But if we're looking for equity by zip code, what I remind staff to think about, we would want all the zip codes to be the exact same color and have the same rate. And it would really be nice if we were at the rate of 22213, if not much lower than that. So this is another way of representing that averages can mask disparities. Some in our jurisdiction have experienced greater exposure risk than others. Slide 5, next. This depicts the cases and deaths by age group. In the top slide with case rate, you'll see in the dotted line the all age rate case, and 3 groups, those between 20 and 59 and those 80 and older experienced the highest rates of cases. My take on this is that the group 20 to 59 were those who had no choice but to go outside of their home given their status as essential workers, whose duties require face-to-face encounters with customers and each other. And those 80 plus were those who had no choice but to encounter essential workers in their quote-unquote own home setting. As we know, the vast majority of these occurred in nursing home and assisted living facilities. And it's because they needed assistance with their activities of daily living, which did not allow them to keep the essential workers from getting within 6-foot distances of themselves. These two groups experienced higher exposure rates, and the latter group experienced the highest rate of complications due to COVID, the ultimate complication being death. So, and in the second graph, you can see the rise in case rate as we increase in age by cohort. So obviously, aging is another unfortunate risk factor that we see not only with COVID, but with other infectious diseases. Next slide. This data shows population, COVID-19 case population, and COVID-19 vaccine population by race and ethnicity. Just to point out, while almost 16% of our residents report being Hispanic, they represent over 25% of COVID-19 cases and only 16% of those with at least one dose of vaccine. That's roughly the percentage of the community, but obviously we don't know who's among the unvaccinated, what that percentage is. I hope it's representative, but it's still a conclusion that we can't officially make. And then over 60% of residents identify as non-Hispanic white, yet they represent 40% of COVID-19 cases and represent 50% of those vaccinated to date. I would say that some of the upstream inequities in our societal systems may play a role in these downstream disparities we are witness to. Next slide. This slide depicts the vaccination rates by age group for those eligible for vaccine. And a reminder, at present, everyone 12 and older is eligible. And among that, so the total is 78.8% of those eligible to receive vaccine have received at least one dose of vaccine. So that's good. And the reason why I say that is for two reasons. It's a fantastic number compared to most places. And we know there are doses of our residents we have received reports from the District of Columbia officially. So I think it's reasonable to say that we should be above the 80% mark when we receive that. So, and if the national statistics are any gauge, they expect 16% of the population is expected to never get the vaccine of their own volition. So if that is true, we're not far from the 84% mark. I would like us to disprove and go beyond 84, but I want to first get to 84 before we set that as the goal. And once again, this is where you can see how, and reminding the public how aggregate data can mask disparities among the age groups. This may seem shocking, but I would prefer the 20 to 29-year-old population to reach 74% and the 30 to 39-year-old population to reach 80% versus trying to maximize the other populations, because we would, with those two, see a significant reduction among those remaining unvaccinated. If you look at the highlighted areas, and I apologize, it's a little bit tough, just for those two populations, that works out to roughly 26, almost 27,000 people still unvaccinated. And then if you look at the next two groups, 40 to 49 and 50 to 59, that's over 10,000 individuals. So of the 45,000 people roughly unvaccinated in Arlington who are eligible, 35,000 fall in those age groups. So we've done well, and it would be fantastic if those with influence can encourage them to go move in that direction. Next slide. So I wanted to just, the reason why I updated the slide from last year, which I did show you, is to emphasize that exposure risk and complication risk are different risks. And those things still matter even though we have vaccine, because vaccine didn't change why people are at risk or why people are complication risk. And I think sometimes everyone looks at vaccine as the saving grace, and it's a fantastic thing, but I don't want to have people lose sight what put people at risk to begin with in some ways. And so the risk of exposure, I'm not going to read all of that, but it summarizes to the risk of exposure increases as you're unable to stay at home and as you're unable to maintain 6-foot distances to perform your activities of daily living or your work. So that's true for both vaccinated and unvaccinated individuals. This does not mean that vaccines don't work. It means that among the unvaccinated, your risk of exposure goes up when you're unable to keep distances. The same is true for the vaccinated. It's just that if you are a vaccinated individual and get exposed, the likelihood of having complications is going to be significantly less than those who are unvaccinated. And the risk for COVID-19 complications increases as your immune system becomes more compromised, including having chronic medical conditions and or as you age. And of course, having the two together amplifies that complication risk. And so with the Colonel's, Colin Powell's recent death, it's a reminder, apparently in the news, he had multiple myeloma. It's a type of bone marrow cancer. And now you have, so he's immunocompromised, but he's vaccinated, but also being in his 80s. That's another complication that if you get ill, it'll be harder to fight it. So it's just to remind people that the risk of exposures and complications may be disparately experienced in our communities, and sometimes it's because of how society organizes itself. Some people will say, are you saying age is the risk factor? Not necessarily, but if we don't have the right controls to say infection control is even more important in congregate care facilities, well, then they may not have the resources or the desire to put in more stringent infection control measures to protect everyone. So those are some of the things that I'm using the opportunity just to remind everyone, whoever's influential in our community, to remind people there are things that we can still do. I wasn't sure if at this point Dr. Miller wanted to say anything about testing, and then I can then go on to the vaccine.
Sure. Just a brief update, because I like to keep you apprised of where we are with testing within the community. To date, Arlington County has seen about 367,000 PCR tests conducted and reported to the Virginia Department of Health. About 64,000 of those have come from Arlington County provided sites, still around the 20% mark that we have hovered at for the majority of the pandemic. The 3 sites that we have remain Virginia Highlands Park, Courthouse Plaza, Arlington Mill. They are open 11 to 7 every day. No appointment necessary. No insurance is required. No doctor's referral is required. If individuals would like to make an appointment, the last appointment is accepted at 6:30, so it leaves time, obviously, to collect and process the individuals through. Easy, readily available, no age requirement. I cannot speak highly enough of them. I have used them on more than, at this point, I would say, 10 occasions, because like many individuals in the community, I have a child that is too young to be vaccinated. And with every illness that comes with school, we opt to take Dr. Varghese' advice and make sure that we are testing, making sure that we're protecting not only ourselves, but members within the community until she is able to get vaccinated. So I highly encourage individuals out there, if you wake up with the sniffles, it's new. Even if you are vaccinated and you're still just not feeling well, use those testing services, know your status, and help protect you, your members of family, and the community. Thanks.
Thank you. So moving on to some of the good news on the vaccines, I thought I'd first talk about the adults and then have a separate slide on children. So let me review the information you see here. So in the top line, you'll see Johnson & Johnson, and it was approved. It's still under FDA EUA for those 18 and older, and that's been since February. They have not submitted an application to the FDA for consideration for additional doses or booster. Officially, the booster is pending at this point. Hopefully this week we will hear that it's been approved. Moderna, it's been approved for 18 and older under the EUA. The additional doses were approved in August 2021, and the booster is pending. And just as a reminder, I just realized to make sure people understand additional versus booster, an additional dose is for people who may not have had a strong enough immune response from the primary series. And so in the mRNA case, that would be 2 doses, 3 or 4 weeks apart, and then they, based on the studies, felt that there was some degree of reduction in immunity. And so it's not like it falls off a cliff. You have time to go get your booster. And then Pfizer has had the approved for use for 18. I should have corrected that. All of those are approved as they are listed there, but actually for additional doses, it's only for or it should only be for 18 and older. So the same for boosters. My apologies, we will correct that. And as soon as Moderna and J&J are available, our clinics at Walter Reed and Arlington Mill will be able to accommodate, and then we'll be doing all three at those sites. They're currently being done by appointment, and they should also be available at the area pharmacies. And we have, I still believe, over 30 places in Arlington and in 26 square mile jurisdiction. So there are multiple options for our residents, either if they live, work, or play here, or if they work or play in other places, they should be able to get access. Moving on to the next slide. So I think people really want to know the status of vaccines for those under 18. Right now, nothing has been submitted for Johnson & Johnson. Moderna, as we've said, the 12 to 17 category has been submitted. It was submitted back in June, and we know that the FDA at some point asked for additional data, so that's why we suspect it's pending. We're anticipating, if you believe all the reports in the press, 6 to 11 would be sometime this fall, but once again, there have been nothing scheduled, so right now, once again, I'd say under 6 would be speculation. So the entire focus is on Pfizer. 16 to 17 is now under full license. 12 to 15 is under FDA EUA. Both of those, that's where this is more appropriate. They haven't been considered for additional dose or booster. The 5 to 11, the FDA advisory panel meeting is scheduled for October 26th, which is next week. So assuming that goes well and they actually approve that, then it would, or recommend it, it would then go to the FDA commissioner for their decision. Typically, the ACIP meeting, which I believe has been scheduled, will be a few days later, and they will then consider which age groups and so on they would officially recommend for doctors to actually prescribe. So if all goes well, it could be as early as the first week of November when they're available. And let's go to the next slide, because this is some of the stuff that I think people really need to be aware of. So pending the official approval in the next 2 weeks, supplies will be allocated to each state by CDC. VDH is going to determine the allocation formula. Here's the part that people need to realize. This will seem deja vu from last December and January. We expect that initially there will be limited doses and supplies because the dose for children is not the same as adults. It doesn't mean that the U.S. hasn't actually purchased enough vaccine for all children, but just because it's been purchased, it has to actually be produced and be in CDC's hands. So, and at present, without hearing what the deliberations at the meeting, there is no proposal for using or adjusting the adult dose to make it appropriate for children. So the return of per capita allocation is entirely possible. I think likely the state will modify it slightly for the actual uptake that's been seen for 12 to 19-year-olds in each community. But that doesn't mean, first of all, if there's a limited supply, if it's per capita, there's only going to be so much coming to each state, which then gets divided. And so it will likely take a little bit longer than people had wanted. So we're waiting for all the T's to be crossed, I's dotted before we make any public proclamations. Having said that, we are planning for vaccination clinics, which will be by appointment because it's the only way to assure the distances and to do things safely. The current plan is to do something similar to what we did back at the end of May and through the summer, having weekend clinics solely for children. The difference is we were able to do sometimes 3-day weekend sort of activities because school wasn't in session. It's going to be, of course, harder to do that. So we would do weekend clinics and then add or reduce some of the adult slots during the week to have additional kids go through so that way we can get the supply out as quickly as possible, but using a sustainable structure so that if we get, say, 2,000 doses, we'll have a week to 10 days to get all of that out. So we'll have the capacity, but once again, like last year, and as Dr. Miller would always say, we need to have the vaccine to actually be able to give it. So I hope I'm wrong in reading the tea leaves, but this isn't the first time we've heard this before. So, and then whatever the initial uptake is, we're going to reassess after we have about 16,000 kids who fit in that category. At some point, maybe halfway through, we'll reassess if there seems to be a slight drop-off. Do we need to continue those large clinics, as well as thinking about targeted neighborhood events, and then ultimately doing some in-school vaccination, but getting a prior parental consent. But of course, that's a bit more complicated process. But then we would use our school health nurses, supplemented by division staff, to help do it in the schools. But we have to maintain the healthcare standards, not the school standards. So we still maintain 6-foot distances, although schools are permitted to go as low as 3-foot distances. So that's one of the reasons why doing it in schools is not as readily an option for us this time compared to H1N1, because the distancing is difficult, and then that could reduce the instructional time for folks if we're taking over spaces. So next slide. So I know people love prognostication. This is a first. Okay, vaccines for children greater than 5 and under 12 should be coming with the caveats I've talked about. Vaccines for those between 2 and 5, the earliest I can imagine is sometime at the beginning of next year, springtime. And beyond that, I'm not even going to try to speculate. So we continue to recommend those who are immunocompromised to get the additional doses for those that are approved, and boosters for waning immunity for Pfizer, and then soon for the Moderna and J&J. As a reminder, COVID variants will still be possible until the majority of the world is vaccinated, which is unlikely to be at least until end of 2022 and likely into 2023. Equity issues will continue, as I've talked about. The upstream policies need to be examined by society and altered if we want to reduce the risk to certain groups already mentioned. And the takeaway of what people can still do will be this, and a visual: continue with the layered strategies or the Swiss cheese model to reduce risk of continued exposure to COVID, as no vaccine is 100%. It helps you, your loved ones, and our community. And so, next slide, final one. This is that Swiss cheese slide that staff modified from a virologist named Ian McKay. And no single strategy or Swiss cheese layer is perfect at preventing the spread of COVID-19. Each strategy has weaknesses or holes. Use multiple overlapping layers to block more holes, and it reduces how much COVID-19 may get through. This graphic and a one-page handout is on the website and is in English, Spanish, and at least 4 to 6 other languages. So we encourage people listening to print it out, post up all over the place, because this is really what's important to protect our community as an individual if you're leading an organization, and my recommendation to populations. And with that, I will stop.
Thank you, Dr. Varghese. There's a lot of new information. We've been in sort of a steady work against the virus over the past 2 months, so it's great to get an update. And I suspect those slides might be just time sensitive as to when they apply, but I think we probably all would love to take a look at them if we can. I don't know if there are questions. I just have one, and it's regarding 5 to 11-year-olds. I think the whole community is waiting for that, is excited for that. Would the weekends, would it be Walter Reed and Arlington Mill that would continue to be the sites for those weekends? We wouldn't be going to larger sites, just those two, right?
Well, at that point, it would be those 2 sites. The setup and breakdown of other sites, typically schools, would just be really quite difficult. So we wouldn't have on those weekends any adult activities. It would be strictly for children. And so part of it's related to the number of doses available as well. Had there been so much more, we would also have pharmacies, but we could have considered larger venues. But given the amount of vaccine that's likely happening, that's going to be the best way. And then obviously parents have the option. We're not encouraging it, but we know that parents will likely do it. They can take children out of school during the day. We're going to we'll have all of our daytime clinics go all the way till 7. And so we're going to allocate slots just for kids as well once we have a better sense of how much we have in hand, so that we'll have the weekend clinics devoted just to kids to get the largest volume out with the available vaccine, and then whatever remaining doses we distribute during the week, and then as supply increases, we'll also release it to pharmacies and other providers out there.
Sure.
But the thing that I have to remind people is it's open to all kids from anywhere. That's going to be the case for all of Virginia and the whole region. Since it's federal vaccine, we can't limit it to, nor should we limit it to, just Arlington.
Sure. Got it. Thank you. Ms. Garvey?
Yeah, I was thinking, while we have you here and we're talking about public health and those that are interested are paying attention, maybe we should touch briefly on flu shots?
Absolutely. We should absolutely encourage people to get the flu shot. Adults especially, you can get the COVID vaccine and the flu vaccine at the same time. There is no prohibition against that. So if you haven't received your flu shot or your COVID shot, please go get both of them. We will not be providing flu shots at these clinics because it's going to be tough enough to probably deal with children and some of their own concerns with one shot, let alone two. But there are many more opportunities out there.
Yep, great. So get your flu shot. I had one other question, if I might. And that I realize whenever we have information about the number of people who are vaccinated, fully vaccinated, partially, how many people do we think have just gotten one shot and they're not going to get fully vaccinated? Is there some information on that? Because I'm guessing there's maybe a good chunk of the population that, just like there's some that will never get a vaccination, there's probably a chunk that maybe will never go for that second.
We haven't seen too many that have gone well beyond 42 days without getting their second shot. There are some, and we try to do follow-up to remind them, encourage them to get that. It actually has not been as much of a problem here in Arlington as perhaps other places. There will be some that have forgotten to come back, and so we have tried sending out reminders.
But there will
For
be.
the ones, yeah, but there will
That's good to
still
hear.
be people.
Yep, thank you. That's good to hear.
And that's just for the ones that we've given that I can't.
Yeah, I understand. We can follow. Yeah, I understand. Thank you.
Thank you, Ms. Garvey. Mr. Dorsey? Oh, sorry, Mr.
You can go with Mr. Carantonis first, it's fine.
Go ahead, Mr. Carantonis, and then we'll go to Mr. Dorsey.
Thank you, Mr. Chair, and thank you for the presentation, the update, and I couldn't be more thankful for the very efficient way, Dr. Miller, that the testing works. I use it myself every week, 10 days, more or less. I see a lot of people, so I think for the same reasons that you are taking the test, I'm taking the test too. And so we recommend for everybody. I had a question about the logistics for the 5 to 11-year-olds. So correctly, you pointed out that we will be running a appointment system for that. So what is the early information that we can give? Where should, when we get approval, what happens next? How do we let everybody know that their kids are now eligible, and how do we instruct them to make an appointment?
Sure. Excellent question. So part of the issue is even with the approvals, the timing of these things becomes very critical in the decision-making process as well. If all goes well, it's entirely possible that CDC will be issuing their approval on a Friday evening. It's been the case for some reason for all of these. I sometimes wish they would do better in their planning, but there you go. And then Virginia has to then issue its approval before we can even contemplate opening up officially things, because you have to weigh the balance. Do we tell people, oh, go ahead and sign up when we don't even know how much vaccine officially we're going to get, because we need to have that many slots available and so on. And so that becomes part of the issue. Whatever it is, we'll do what we did the last time with the kids. I know Brian Helfer and the CAPE team stand ready to work with the school system to put out messaging through the school system as well as through our regular channels to let people know how they can go about doing this. But it will be a computer-based system for the majority. But I know that the DHS staff under Anita are prepared to also help make appointments for those who haven't come up with that. We haven't worked through any of those details yet, but that's partly because we need to be able to let people know what to be told, which is unfortunately one of the other things. We don't know yet what the caveats may be for the vaccination as well. So we've got an infrastructure that's possible, but we don't know which one to release because there's no model in one sense, Mr. Karantonis. We have to build it as we're flying it, but we're trying to build it on what we've already known. I don't know if Dr. Miller has any other thoughts on the topic, but you don't have to. Okay. I don't know if that answers your question.
It's semi. I understand.
I wish I could be more specific and give granular detail, but I think it would be irresponsible of me to do anything more than just the general thing of it'll be once again, just like the adult parents did, going onto the website, scheduling appointments. That will be the vast majority of people will do that, if that helps.
And just to follow up on boosters, so I've seen the slide. So we are waiting for some to be at all approved, and so the population that's first eligible for them is a population that is either immunocompromised or somewhat has a more weaker immune response. So we are inviting. We know who.
We don't know any of those individuals.
No.
That is the beauty of our lack of national health care system. Had we known that, those would probably have been sent out to people. So we take people's word that they know their immunocompromised status. So they're already eligible and they already can get the vaccine. And a number of those individuals know who they are. It's because the group that they're talking about are people like organ transplant individuals. Mm-hmm. So they're usually within care, continuing to receive that level of care. So those individuals, it would be surprising to not have their systems letting them know you should go get that. They're usually instructed in many ways as part of their care to always pay attention to those things. Having said that, it's also self-attestation for immunocompromised states. So we are trusting people when they come, if they say, we're here, we list all the reasons for those who can get the Pfizer booster at the moment, and if they say yes, we give them that shot, or at the pharmacies in the community or doctor's offices. So the immunocompromised, in theory, have been identified. Where the holes will be, of course, are those who are not in healthcare in general. But that was the issue prior to this to begin with. And as I said before, there's little that public health can do unless the larger society starts saying we need a different system. We'll keep putting those messages out. And if they really feel that they're in that category, no one's going to police them in and deny them access to the vaccine. If they're looking, though, for a booster rather than an additional dose, we're close with Moderna and J&J. So I'm hoping those who are hearing who may not have access realize that they have access to the Arlington Free Clinic and Neighborhood Health to develop a medical home and a relationship where they can get those sorts of questions answered about their health care and should they or should they not get those things.
Thank you, Dr. Varghese. I'm really concerned about this category of people who,
I share your
are not
concern.
covered. So, okay, I yield.
Thank you, Mr. Karantonis. Mr. Dorsey.
Thank you. A couple of questions. Dr. Varghese, as far as Johnson & Johnson, I don't know if you know how many Arlingtonians received that shot.
Not off the top of my head, but we have had some, and we've seen an uptake, sorry for interrupting, since the mandates have occurred. It is one of the ways that some people have gotten into compliance with being one and done. We've seen an increase in the number of people coming and getting the J&J vaccines, at least at public health clinics.
So we always theorized that it would be popular among the vaccine hesitant to only do a one-shot regime, but given that the FDA panel recently recommended that the full FDA approve a J&J booster, I mean, two questions from that. Do we have enough supply if that should come imminently? If your calendar is correct, consistent with past practice, panel approves, within days or a week, the FDA follows suit. Are we prepared for the flood of people who may seek their J&J boosters? Because from what I understand, they're recommending it for everyone, not just immunocompromised.
Correct. Well said. So yes, it is supposed to be 2 months after the initial dose. So there is plentiful J&J supply in the market, and we believe we should be able to get doses, and we have ordered some extra doses. We're not ordering thousands because unfortunately we don't believe that the majority of the individuals, and I'd love to be proven wrong, that they will all be rushing because they may have been in the one and done category. So, and for some, literally they may take one and done as I'm done. So hopefully we can encourage people to get the booster. But one of the things that I want to remind people, the J&J data, they have been able to stay at about the 70% mark in efficacy for a much longer period of time. It's just that the medical advisor group felt that given that there was evidence that you could boost that to be higher, so in some ways what's happened with the primary series, so mRNA, especially Pfizer more than Moderna, they've seen a more steady decline. It hasn't gone below 70%, but you know, they seem to be similarly efficacious on those things based on the current data that's available.
Thank you. And I don't know if you can, Ms. Jacobs, if you can pull up Dr. Varghese' presentation and the one with the 2 pie charts, the demographic data. I just wanted to make sure I was capturing and assimilating all that information as you said it.
It's all on our website, but I thought this time doing it slightly differently would capture or raise different questions, because we do not present all of this data all on one slide.
Terrific. So
if you wouldn't mind, I'll be happy to go through each one as just as a reminder.
Sure.
To my far left is the actual population by race and ethnicity, the general distribution based on census data. The middle is the COVID cases that we've actually experienced through a certain point of time in Arlington by race, ethnicity. And then the final is the available data on residents with at least 1 dose of the COVID-19 vaccine. The state data originally had a lot more missing data. That has been reduced significantly.
So I guess another way to maybe approach the narrative here is that, you know, we have minority populations are receiving vaccine roughly in line their share of the population, but we have a significant underrepresentation of white Arlingtonians in the take-up of the vaccine. Am I reading this correctly?
You could read it that way. What I would also say is what we don't know is how many people are unvaccinated in some of the same numbers that I've talked about. So therefore, my concern of any of this data is for the groups that are unvaccinated, what's the distribution there as well? But yes, I think you could say fewer white individuals have gotten the vaccine compared to their percentage in the population. That is definitely true.
Okay.
But I think because I don't know what the distribution of the folks who are unvaccinated, if we go on traditional fault lines, for lack of a better term, I'm sure there's a better term, someone will tell me, if people are hesitant and it's higher in minority and racial and ethnic groups, will we see that the group in the unvaccinated is that a certain distribution? What I don't have the data for that is what percentage of that are Hispanic, Latino, what percentage are African American, what percentage are white in that sense, because it's hard to go and find those individuals to get that information. If that compromise if that's not based on the same degree of the race, ethnicity of that last column there, then that could change the conclusions that I make on the vaccine.
Thank you.
That's the only caveat.
And if I could sneak a third one in, Mr. Chair, just, asking for a friend. If we take the 5 to 11 age group and have a similar performance as we did with 12 to 17, I mean, we're talking about 15,000 shots needing to go in arms, or series of shots going into arms. How long approximately would that take with the levels of vaccine you expect that we'll get, given that it's going to be a new dosage?
All I can say is that what we're hearing is at this point is there will be a limited supply at the beginning, and the initial bolus will likely be the largest, and then for several weeks, it'll be a smaller amount each week. So I'm going to make up numbers at this point, okay? Because if we go on the basis of what we had previously, if they were to give us 6,000 doses, I can imagine the CDC and others recommending that you hold the second dose, which you know is controversial, which then means if you have 6,000 doses, if you hold the second dose, you can vaccinate 3,000 people. And then if each subsequent week, let's say it's 2,000 doses coming, same process, then that would mean 1,000 saving 1,000. So until that changes, whatever that math is that I just came up with, if it was basically 3,000 and then whatever, that'll take us some time. I don't think it should take that long, but that's me hoping rather than knowing, and this is where I'd like to hear a little bit more granularity from someone much, much higher than the Health Commissioner of Virginia. I mean, we need to know what is known, and maybe they're afraid to quite say anything yet because maybe there will be a miracle. But I'd like to hear the specifics to know when are we going to be able to get it out as quickly as possible to vaccinate, because I think we will have interest. But I know there will be some parents who have been less keen on this because they've worried about long-term effects. And, you know, the majority of our parents have gotten vaccinated, but I can appreciate there are people who are worried, so they don't have to jump in line first, and they can see what happens with how the rollout goes with everyone else.
Man, I hope I shared your confidence. Thank you for flagging this for us. As I editorialize, just remembering the days when this started and when the demand exceeded the supply, how not pleasant it was. Think about that as it now relates to kids.
Yeah.
No, I'm glad that you asked the question. It's why I've put it there. Anything you can do to put bugs in certain federal elected ears would never hurt to try to get the question. When will we know more clearly how much vaccine is available?
Thank you.
Because the scientists are not going to be asking those questions at those meetings because it's not technically in their purview.
Thank you. It's hard to forget when we were low on supply in January and February. It's just, I'll never forget that period, but then the work that we did together as we got into March, April, and May, and June, there's progress, but we have to continue to be vigilant and continue to work. Thank you, Dr. Varghese and Dr. Miller, for your presentation and your continued work. It has been 2 marathons, not just one, that I feel like we've been working through, so thanks very much. I appreciate it. With that, we will go, I'll make a motion that we go into closed session. We'll be returning no sooner than 6:30, but as far as closed session, I make the following motion. I move the county board convene a closed meeting as authorized by Virginia Code sections 2.2-3711A1, 3, and 8 for a discussion regarding the performance of one board appointee and the appointment of a board appointee, and a discussion regarding candidates for appointment by the county board, and a discussion regarding the